Hi, and welcome to our program, Counteracting the Disease Continuum in Metastatic Hormone-Sensitive Prostate Cancer. I'm Dr. Brian Rini. I'm the Chief of Clinical Trials at Vanderbilt Ingram Cancer Center, and I'm joined today by my colleagues, Dr. Gillessen and Dr. Sweeney. I'll have Dr. Gillessen introduce herself first.
Yes, hello, my name is Silke Gillessen. I'm a medical oncologist from Bellinzona in Switzerland.
Hello, I'm Dr. Christopher Sweeney. I'm a medical oncologist based in Boston at Dana-Farber Cancer Institute.
Thank you both for joining. Our faculty disclosures are now displayed on the screen. If you missed it, please make sure to check out last week's tutorial on hormone-sensitive prostate cancer and keep an eye out for another one that'll be released later this week. During today's program, we'll be addressing the following learning objective: differentiating between patients with metastatic hormone-sensitive prostate cancer with different prognoses defined by different clinical features, and also helping to select the most appropriate therapies in addition to their baseline androgen deprivation therapy. Dr. Gillessen, would you like to start us off by discussing prognostic stratification in metastatic hormone-sensitive prostate cancer?
Yes, thanks, Brian. So I guess the whole thing started because we have put everyone with metastatic hormone-sensitive prostate cancer a bit in the same box for treatments, but also for studies. And I guess we know more and more about the different prognoses of different patients. And it is very important because we obviously want to do, also in prostate cancer, some kind of personalized treatment selection. And as always, is very important. The patient should be in the center. So there is a patient preference. So you should discuss always with the patient the different options, but also the life expectancy of the patient that we all know is sometimes very difficult to estimate, but also the comorbidities, the co-medications, the frailty of the patient. And then there is more country-specific things like access. How much does the patient have to pay out of the pockets for the states? But then also kind of approvals in other countries that can be even different from country to country in Europe. And then now with the COVID surge, obviously we had also a new concern about safety. So how many times has the patient to come to the clinic and has a risk to get an infection like with COVID in the time where we didn't have the vaccinations. So these are new aspects that we haven't thought about more than 2 years ago. From the side of the cancer, there is the prognosis that we want to talk a bit more in detail about synchronous, so de novo presentation versus metochronous presentation. That means after an attempt of curation with a local therapy, a relapse with metastasis, and then lots of discussion about metastatic burden. We're going to discuss that also more in detail. And then obviously the future should be that we also include biology, molecular profiling, and so on. And we come to that in a later time point. So the disease spectrum in reality is really wide. So patients with a metachronous or relapsing presentation, so metastasis after curative radiotherapy plus minus also radiotherapy and operation, have a longer survival than patients who have a de novo metastatic presentation. And we also have seen data that the more bone metastases there are in conventional imaging, the worse. And there is always that discussion about visceral metastasis, but we also know now that probably the really important metastases are the liver metastases that give you a poor prognosis. So there is a lot of discussion about that, and also a lot of retrospective data that we're going to show later. You had that screening for prostate cancer in the States, and then you stopped it. So it seems that the incidence of de novo metastatic disease has increased after stopping the screening as a recommendation. And that's very interesting because in Europe, there is again a big heterogeneity because every country does something different. So there is also really countries where we see a lot of de novo metastatic disease because there is no screening, maybe because there is no screening. That could also be an association. And there's other countries where a kind, at least of a selective screening is done in men. So I think this is a very important question. And I guess we know now it's an association that, the screening with the de novo metastatic diagnosis, I think we need probably a bit more data and a bit more time to see if it's really also really correlated. But the fact is that we probably going to see also in the States more de novo metastatic patients. And we have another novelty, and that's PSMA PET-CT. It's a very accurate staging, and we have just now a lot of Twitter discussions going on with that. But we, in the moment, don't really know if it changes outcome in patients. So especially in the high-risk localized patients where we 5 years ago have done the staging with CT scan and bone scan, and where we now use PSMA PET-CTs, we see a lot of patients with metastatic disease that you don't see on conventional imaging. So in that sense, you have a potentially curable patient who you would have treated 5 years ago with curation, local therapy, but now have this doubt of metastatic disease. And I think this is really important that we are aware that there is new questions coming up when we're using PSMA PET-CT. Of course, it's a very good, very accurate imaging tool, but it also poses a lot of new questions. So yes, it identifies more disease than the conventional imaging, as we call it, CT scan and bone scintigraphy. But we don't really know if the management change that we induce with that is always better for patient outcomes. And we also don't know if every positive result on a PSMA scan is really a metastasis. And obviously we can't confirm them all with biopsies. And here's a lot of question coming on. So should we treat patients who have low volume disease on conventional imaging and then PSMA PET-CT? High volume disease like high volume disease or like low volume disease? And is really PSMA PET the tool to identify the best candidates for SBRT, so local treatment of metastasis? I think that's a very important question. And again, the high-risk localized disease, that's actually where I see the biggest questions right now, because we're doing regular staging for high-risk localized disease with PSMA PET-CTs, and we see there a lot of not so clear lesions, specifically in the bone, specifically if you don't use gallium, but the fluoride PSMA PET-CT. And I guess that's really something where we have to learn much more. And here you see a very nice, actually, publication from Chris Sweeney's group, where you see that it's really making a difference. So you have here the metachronous low volume disease, where the patients have a median overall survival of about 8 years, versus the worst group from the de novo patients, high volume, with a median survival of 3.6 years. And as you see, that's really an impressive difference of these two extremes. Here you have the prognostic groups and the definitions we did for poor prognosis versus good prognosis. I want to really concentrate on charted and latitude, because that's the two that we really use most right now. So charted, again, Chris Sweeney used a definition called volume, whereas high volume was defined as 4 or more bone metastases, and at least one of them beyond pelvic bones or vertebra, or having visceral mets. And here comes again this question, are really all visceral mets the same? We don't think so. We think lung is probably prognostic better than liver. And Latitude, again, used another definition that was called high risk. And for that, you should have 2 out of 3 characteristics, at least an 8 or more, 3 or more bone lesions, or again, visceral metastasis. Again, without making the differentiation between liver and lung. And again, you see big difference in OS. And this is a bit the dream, I would say. So Chris Sweeney and I hope a bit that we can get into a better prognostic classification that's more accurate, like we, for example, have for testicular cancer, where you have a number of risk factors and then could make more classification of good, intermediate, poor. Again, this is really just something for the future that we can think of, that we would say liver metastasis is really bad, more than 4 metastases, probably also 5, some people would argue. De novo presentation, we know there is also other clinical signs like lytic bone metastasis, a low PSA, and lots of volume. So I think we can refine that a lot, but maybe we should think about a better classification for our patients with metastatic hormone-sensitive disease. And with that, I leave to Brian and to Chris to have your comments.
Okay, thanks, Silke, for that excellent discussion. Let's take a pause here and talk a little deeper dive into some of these topics. So my first question, I'll direct this maybe to Chris, is do you think most treating physicians account for the synchronous versus metachronous presentation and extent of disease? Do you think that calculation, is part of most people's intake, if you will, of a new hormone-sensitive metastatic patient?
I really don't know the answer. It'd be interesting to see the results of the APCC poll, the tutorials and the polling that's coming from this more community-based outreach with this integrity webinar. I think it depends on how many patients you see with metastatic prostate cancer. And the more you see a disease, the more you get a feel for different patterns of behavior. So I think high volume physicians who see a lot of prostate cancer would recognize the slow indolent progression of a metachronous low volume patient. But I think you've got to see the broad spectrum to know the difference. I had the benefit of working at the VA earlier in my career, and I saw a lot of high volume de novo metastatic. And I said, well, we really need to do something about this, and hence the chartered study. And when I worked at the VA, we had a lot of relapsing patients. So I think you've got to see a lot to actually get a feel for it. However, by this outreach and this type of webinar and showing the actual data, I think we'll get a greater uptake of this recognition.
And Silke, what do you think? Is this something you record in your notes when you're seeing a new hormone-sensitive metastatic patient? Do you have a template or something? Do you record synchronous versus metachronous? Do you record volume somehow on every patient, or not necessarily?
Yes, we do. We have a DKG certified prostate cancer center. So there we have it in our tumor boards that you have to click the volume and the relapsed versus the de novo. So we do that a bit routinely. I think in Europe, most of us believe in the STAMPEDE data with the radiotherapy to the primary for the low volume patients. So that even if STAMPEDE calls it in that paper burden, it's actually using the charted definition of low volume. So burden and volume there used synchronously. And there in Europe, I think we have taken up that data. So for that decision, it is important if you give an additional radiotherapy to the primary, to the low volume patients. And I know that states that hasn't maybe not that much, but I leave that to you.
So I would pick up on that and say, I think we do need to encourage greater use of radiation to the prostate in men with de novo low volume. But Brian, I think for 50 years, just a patient with metastatic hormone-sensitive prostate cancer, we've started androgen deprivation therapy, full stop. And a lot of people, I think, hopefully, with the greater uptake of the add-on therapies matched to patients with a given clinical profile, will actually have greater uptake. So you only do something, a test or classification, if it's going to impact your treatment decision. So I think a patient with de novo metastatic prostate cancer will talk about what are their treatment options. high volume de novo metastatic disease, metachronous low volume. So I think if we tie particular treatments to a particular patient classification, we'll get greater uptake because people will see the need.
Thanks. And do you think, we're going to talk a little bit later about sort of the definitions of high volume and low volume, and I know that they've been a little different across studies. Do you think the cut point, if you will, matters? It's obviously a continuum of tumor burden or tumor volume. And Chris, maybe start with you. Do you think the definitions, do you think they matter? Do you think there's some flexibility there? Do you think there's some low volume defined patients who maybe should be treated as high volume or vice versa?
Absolutely. So every classification, be it a biomarker, be it a clinical variable, but by scan uptake, be it a conventional scan, be it PSMA PET, all have misclassification. Nothing's perfect. But by and large, as you can see, we've got if we had a PET scan despite a outcome of 3.5 years versus 8 years, we would say that that's the best thing since sliced bread. But because we're using conventional old scans, it's less exciting, I think. But every definition has a clearly misclassification. So absolutely. However, the bigger challenge is when the academic community start throwing out all these different definitions and competing, one's better than the other, it confuses the regular physician who's treating every disease, not just prostate cancer. And so I'm going to say out loud and proud, let's keep it as simple as possible for right now. 4 or more bony metastases, regardless of location, I think is a reasonable cut point. And there's some variability around that. And liver metastases. If you see those patients, I would say we really need to double down and consider them as high volume disease, and most of them are de novo high volume, and will come into the treatment options for those patients. So just for simplicity, for uptake in the greater community, 4 or more bony metastases, liver metastases, double down on treating those patients.
And then last topic for this discussion section, which is kind of a big one, is about PSMA PET. I mean, we're clearly entering the era of advanced imaging. And I think the cases we'll talk about today are with conventional imaging, which is what we've done for all of our careers. But now we're quickly entering the more sensitive imaging and PSMA PET, which I think will certainly become widely available. How do we think that's going to change management of prostate cancer? I know it's a big question, but maybe give me your top 2 or 3. For instance, high-risk disease, rising PSA, advanced disease. Where do you think it'll result in the most benefit for patients? Not just change in management, but benefit for patients. Maybe Silke, if you don't mind going first.
No, of course. So maybe if I can say one thing to your first question. Noel Clarke's group has looked at that pretty extensively, and you're absolutely right. So the number of bone mets is a continuum, and that's interesting. No, it's not a cutoff like poof. But as Chris said, we have to make our life as clinicians also pragmatic. But it was a continuum in Stampede. So I think that's interesting, and we can learn from that probably. So for the PSMA. So for me personally, I have to say, in the metastatic setting, in the moment metastatic castration resistant, I think it's obviously very useful as a biomarker to choose treatment with lutetium PSMA. So there, I think it's a clear cut, for me, very useful tool. It's like a biomarker. If it's positive, if it fulfills the criteria, you can send the patient, at least in Switzerland, to the lutetium treatment, and it makes sense. For personally, in mCRPC, for patients who I don't want to give that treatment, I wouldn't use it, because I don't see what it adds to our conventional imaging that, at least in Switzerland, is cheaper and easier to get. It's faster and everything. For the patients, obviously, it has a big advantage because it's 1 imaging instead of 2. So it is nicer, it's logistically nicer for the patients. But in the moment that is for us, it's not so easy to get a spot to do it for everyone. And it's not approved in that setting if you don't want to give the treatment. So for the high risk, as I already alluded to, it's creating in the moment, I have to say, a lot of new problems, because we see lesions where we're not in the bone, especially where we're not sure if it's really something that you can't see in the CT scan, you can't see in a MRI, and you're asking yourself, is it something or not? Obviously, then you can. It's very difficult to biopsy because you would have to go to do a blind biopsy, what obviously patients and we don't like. So for me, there's still these questions of the wrong positive lesions in the bone, especially, that would make you maybe go from a curative approach to a palliative approach. And I think that's, for me, not solved yet. If it's negative, it's very reassuring. If you have a high-risk patient that has really only localized disease in the PSMA PET CT, I think it's very reassuring. So then you can do your normal high-risk treatment. If you see something in the bones, it maybe in the moment poses more questions than it really answers.
Thanks. So Chris, we're running out of time in this section, but I'll give you 60 seconds to give us your answer.
So the answer is, you only do a test if it's going to change management. And in the US, the challenge is it's actually harder and more expensive to get the PSMA PETs right now, and more expensive. And I'm using what we're doing in the ENZA-RAD experience. We get the conventional scan, we get the CT with it, and we actually look to see what's on the bone, sclerotic changes or the like. So if there's sclerotic changes with the PSMA PET uptake, I think that's, and the pretest probability is high, it's metastatic disease, I think. Whether you need a bone scan, I asked the question, is it going to change management? If a patient has multiple sclerotic lesions on the CAT scan, the PSA is high or liver metastasis, getting a bone scan is not going to change. We have to keep asking, how is it going to change our care for the betterment of patients? And to Silke's problem, very quickly, high-risk localized disease, uncertain about PSMA PET findings, do not undertreat. Treat with curative intent. Local therapy plus systemic therapy still cures patients in that setting, and we do not want to undertreat those patients.
Great, thank you. We're going to move on now to talk about a patient case. A 58-year-old man presents with low volume de novo metastasis, so hormone-sensitive prostate cancer. He had a screening PSA of 20, had not had prior PSAs, was asymptomatic without comorbidities. It's a prostate biopsy, which reveals a Gleason 4+4, so Gleason 8 and 4 of 12 cores, has conventional imaging, and has bone metastases in his T7 and L5 vertebrae, as well as a 2-centimeter pelvic lymph node. So there are different algorithms for the management of metastatic hormone-sensitive prostate cancer. There's one from AUA, Astro, SUO, so different organizations involved in prostate cancer that just sort of lays out sort of the normal time course and what to do for these patients. And it's really what happened to our patient, what we've been talking about. Assessing the extent of disease right now with conventional imaging, so bone scan and CT scan, notwithstanding what Chris just said, assessing the extent of metastatic disease, so high versus low volume, again, thinking back on our discussion of those definitions and some of the cut points that are used. I think assessing whether the patient's symptomatic from disease, and I know if I have a patient who has a more critical bone lesion, so a lesion in a weight-bearing bone or something, quite obviously that sometimes demands immediate local attention. And then we're going to talk about the different treatment options for this patient. These algorithms talk about considering periodic conventional imaging, and I'd like to come back to that in our discussion for when and how often for these patients are you doing imaging. And then the last part is about genetic counseling, which I think is important. It's really recommended for any man with metastatic prostate cancer. I think most institutions apply that a little more selectively, and perhaps we can come back to that as well in the discussion. So what are the treatment options? APCCC asked this question on Twitter, and basically the hormone therapy, radiation to the prostate, and androgen inhibitor got the most votes at 75%, so less use of docetaxel on that one Twitter poll, more use of the hormonal agents. And then a follow-up question was, if you selected radiation to the primary and systemic treatment, would you also add radiation to the metastatic sites? And about 2/3 of respondents, 65%, answered yes. So I think these responses suggest, increased role of radiation in these patients, which I think is something that's developed over the years that we'll certainly talk about. And I think, certainly in the last couple of years, what's happened is we have a lot more tools in the tool bag to treat metastatic hormone-sensitive prostate cancer. And I know this is an analogy, Chris, you like to use, it's a chess strategy, and the more chess pieces we have, each of which does a little different thing and has a little different rules around it, might be appropriate for a given patient. And it's not necessarily one or the other. It might be one, then the other. It might be a matter of sequence or combination. And I think this patient is along one spectrum of prostate cancer. And I think, as we've been talking about, there are very different types of these patients that can walk in the door. There's the young patient with more aggressive de novo disease, maybe visceral disease. And then there's the older patient with comorbidities who has metachronous disease. And those are very different in terms of how many treatments we may choose for that patient, how aggressive we're going to be in moving these chess pieces around, if you will. So I'd like to go back to sort of the case and the options. Silke, I'll start with you. So you have this young, very healthy patient, de novo metastatic prostate cancer, 2 bony sites, a pelvic lymph node is asymptomatic. What would be your treatment approach for this patient?
So I guess that's on conventional imaging. I think you said that.
Yes.
So I would probably go with the Twitter poll, the ADT plus the radiation to the prostate. I would not only irradiate the prostate, but also the lymph nodes, the involved lymph nodes. That's always a question in Stampede, where we get our data from, and also in horror, it was actually the primary. But I think a lot of us think now that if someone has clearly a lymph node, that we take an involved feed also from the lymph nodes. So I would add that. And I would also discuss with him to add Abi or also one of the amides. Normally, to be honest, abiraterone, because we know about that combination from Stampede now again. And tell me, Chris, if I say too much Stampede. And then for me, I think I want to do this a bit word of caution. The SBRT to the 2 metastatic sites, to be totally honest, here in my center, we would discuss it with the patient, but clearly say that this is not a standard of care and we don't know if it really changes outcome. I guess that is something to consider. And the other consideration, if I may, and I'm interested to hear what you and Brian think, and also Chris thinks, maybe if someone goes then really down to 0 with the PSA after 2-3 years, could we even think about stopping treatment, the systemic treatment? That would be something that I think we don't have enough data yet, but could be very interesting for such a young man. And as you said, germline counseling first and then germline testing, I think that is very important.
And Chris, in our next section, you're going to talk through a lot of the data that really leads to these different answers. So without going into that yet, what would be your approach to this patient?
So there is what I do with my heart, and then there's what I know with my head. I apply a bit of an M&M strategy here, one shot, one opportunity. So, and you're managing what we know from data, from the trials, and what we know from patient treatment burden type of issues. I think a lot of people know that we see benefits in these patients with radiation to the primary, with the hormones Abi and as monotherapies. Maybe a benefit, but it's a smaller benefit with greater toxicity with docetaxel. So that's why I think we see people steer away from docetaxel, treatment burden and documented benefit. So we do not have data, as we've discussed, for the combination of radiation to the primary with or without abiraterone yet. That will come with the piece 1 data eventually. It's a fantastic study. So I do radiate the primary and add on a hormone of choice, thinking to maximize local and systemic control. And that's based on some anecdotal experience. Yes, anecdotes where I have stopped therapy after 2 years just with ADT and radiation alone to everything. And there are a number of patients who I see, and it probably is that 20%, magic 20% number we see for oligomets, who had 5+ years disease-free, normal testosterone, PSA never rose again. May happen later. So with my heart, I radiate the primary, long course hormones 2 years, and radiate the mets if can be covered by SBRT.
So I think my approach is similar. I think we're going to talk about the piece 1 data. I think for this young patient, I would also think about integrating chemotherapy, but we're going to sort of get into that. I have to admit, I haven't gotten to the point of stopping therapy. And you both see more prostate cancer patients than I do, but I haven't really gotten maybe the courage or the number of patients where I'm getting those patients where I'm, who have had this aggressive therapy plus radiation where I'm stopping therapy. But I think it's certainly intriguing and, of course, it benefits of patients. Why don't we move on to the next section, Chris? You're going to take us through a lot of the different options and data.
Thanks, Brian and Silke. This is a fantastic conversation. A lot of what we've discussed is basically coming down to the notion that we have a lot of data that has come through since 2014 in the last 7 years, and different treatments with different treatment burdens, and we're seeing different treatment effects in different groups. And there's extrapolation of data, there's looking for consistency across data sets, all with the goal of how to work out what is the best treatment for a given patient. So here is the extensive data set that I just mentioned. So just recognizing from the 1940s to 2014, we were just treating patients with testosterone suppression alone. And for simplicity, I'll use the term ADT, but our hormonal therapy is a bit more complicated than just ADT now alone, because we've got agents like abiraterone, there are extragonadal androgen synthesis inhibitors and potent androgen receptor inhibitors, apalutamide and enzalutamide, that prolong survival. So when I say ADT, I'm just referring to testosterone suppression alone. And as you can see here, we've had 3 studies evaluating docetaxel, GTUG15, Charted and Stampede, Arm C, 2 studies evaluating abiraterone added to ADT, Latitude and Stampede, 2 studies with enzalutamide and 1 with apalutamide, 2 studies with radiation to the prostate, HORAD and Stampede, and more recently, the academic studies, ENZAMET and PEACE-1, adapted their trials to allow patients to receive docetaxel as standard of care with the ADT, testosterone suppression alone. And we're now getting a question, are there patients who benefit from the addition of docetaxel? I also just want to point out, yes, there's a lot of data here, and some of this, most of this data is actually coming from cooperative group studies, and which answer questions for drugs that are, or therapies like radiation, that are not a part of any pharmaceutical financial planning, if you would. So I cannot emphasize the importance of more facile designs that are not tied to regulatory issues, and therapies that are not tied to patent lifespans. So let's just have a very high level look at the studies of testosterone suppression, ADT, with or without docetaxel. What one can see here is that for all comers of M1, be they low volume, high volume, metachronous, synchronous, you can see that GTUG15 was read as a negative study, although a treatment effect of 0.88, Charted with longer follow-up was 0.72, and Stampede Arm C 0.81. Now, if we go into looking at the patients with greater granularity, we can see the high volume de novo and metachronous tended to have a greater treatment effect in the GTUG15, a greater treatment effect in Charted 0.63, and less of a treatment effect in the Stampede Arm C. There is some consistency across the group for the benefit of docetaxel in this group. The Charted and the GTUG15 studies were pulled together, and it was clear that although GTUG15 was read as a negative study, the findings were consistent. They just had smaller patient size. But then if we look at the low volume and de novo metastatic, we see more of a mixed signal. GTUG15 and Charted, one would read that as a negative, especially for a cytotoxic with a significant treatment burden, that there was not a survival benefit for the de novo low volume, granted its subgroups and its small numbers, but we see a consistent lack of a big signal. What I would say is that Charted did look at all of its patients and stratify them prospectively by high and low volume, so we have 100% scan data. The GTUG15 team went back and got 100% of their scan data, which is an impressive feat retrospectively. And Stampede, they actually saw a treatment effect of 0.76 with confidence intervals crossing 1. And although it's 362 patients, 124 of the patients got docetaxel in the 2-to-1 randomization. So I look at that with an asterisk as I put there. It was retrospective. They didn't have the data on all of the patients. So I think there's some inconsistency and some uncertainty about that data set. So I do not offer docetaxel for low volume de novo metastatic patients because of treatment burden and less of a clear treatment benefit. But I've got the amber around that because that's not a super strong statement. But it's a clear red: do not give, do not do, stop. Do not give chemotherapy to low volume metachronous, and I have heard people do this where we clearly see no evidence of treatment benefit in terms of overall survival for this very good prognosis, these patients who have a much better prognosis. When we turn to an analysis of the hormonal therapies with abiraterone and stampede in basically de novo metastatic hormone-sensitive prostate cancer, Enzamet with enzalutamide, apalutamide in Titan, and enzalutamide in Arches, one can see for all comers M1 across the whole spectrum, low volume, high volume, metachronous, synchronous, the treatment effect was about between 0.6 and 0.68, a very clear signal. And that signal was very clear again, no matter how you classified the patient's high volume or risk, with treatment benefits ranging from 0.54 to 0.68 across the spectrum of the disease. And we also see a very consistent signal in the low volume, low risk, which we did not see with docetaxel, ranging from 0.39 to 0.72. Again, very clear, very consistent, all in the same direction. And then if you look at the metachronous low volume on the far right, this is the first time we've ever seen a survival benefit in patients with metachronous disease, most of whom have low volume disease. We've done an aggregate meta-analysis and published that in European Urology, and it's close to a 60% decrease in the rate of death. For metachronous low volume, we published in the European Urology showing that the 3-year survival for that very good prognosis group goes from 83% to 91% with the addition of enzalutamide to testosterone suppression. Longer follow-up will come, and we'll see if we can continue to see that finding and see what the data is at 5 years. Hopefully in the next few months, we'll be able to present that. But that's the first time we've shown a treatment benefit in that group. And I just want to emphasize that. And on the next slide, we see the data supporting radiation for patients with low volume de novo metastatic disease. Here we see 2 studies in a meta-analysis combined, aggregate meta-analysis, the Stampede and HORAD, where they both characterized patients by whether they had less than 5, so 4 or less bony metastases. And one can see a clear treatment effect that's consistent across both studies with an hazard ratio of 0.73, so a 27% decreased rate of death, 7% improvement in 3-year survival, with adding radiation to androgen deprivation therapy, just testosterone suppression alone, and no clear evidence of benefit for those with 5 or more bony metastases. So this, I think, is a very, very reasonable option. Lower treatment burden, more more consistent treatment efficacy in this subgroup. Now, you may well ask, what about the role of hormones versus testosterone suppression with abiraterone or docetaxel? We do not have direct comparative data. Really, at the end of the day, one versus the other, there's not that much difference in terms of overall survival, but with chronic longer suppression of hormones, both extragonadal and gonadal derived with abiraterone compared with docetaxel, there was a much longer time to PSA relapse, failure-free survival, maybe a slight decrease in metastatic progression-free survival, but no difference in overall survival. And this was a period of time where the 2 arms were accrued to, but not directly randomized against each other, of abiraterone or docetaxel in the Stampede. More wonderful data that comes out of a fantastic platform study. But we have to recognize it's 566 patients, 60% of them were M1, 22% N1, and 70% N0, M0. And these patients would be also included in the recent Stampede abiraterone N0 study that Gerda Tard just presented, just showing that there's a bit of a mixed bag within the Stampede N0 and M1 patients. So the question comes, and Dr. Rini threw the gauntlet down saying, well, who should we be giving docetaxel to in combination with the hormones abiraterone or apalutamide or enzalutamide, so-called triplet therapy? So we now have studies that have provided some data with varied degrees of maturity. The top 2 are testosterone suppression plus or minus apalutamide. 11% and 18% had prior docetaxel. There was a clear rPFS benefit for adding apalutamide to docetaxel in those who had prior docetaxel, 0.47, but the hazard ratio was 1.12 with huge confidence intervals because of small numbers. With the ARTIST study, 18% had prior docetaxel. I don't have the numbers of how many of those were high volume, but they had a hazard ratio of 0.74, but wide confidence intervals again. So no clear signal for adding apalutamide or enzalutamide to testosterone suppression after a patient had docetaxel. The first cab off the rank that really provides some data is PEACE-1, We'll not go into the details of this study because it's very complicated, but we will focus on data that was presented at ESMO by Dr. Fazazi on behalf of the PEACE-1 team. 60% of the patients in this study had concurrent docetaxel. Some also got radiation to the prostate, but there were 710 patients who were basically testosterone suppression plus docetaxel, plus or minus abiraterone, and some got radiation as well. Median follow-up of 42.6 months, 64% high volume, a clear RPFS benefit for high volume of 0.47 and 0.58 for low volume, but a clear survival benefit for patients with high volume, 0.72, with a significant p-value and confidence intervals less than 0.95. But the de novo low volume, and I'm emphasizing it's de novo low volume because only de novo patients were accrued to this study, the hazard ratio was weaker, 0.83, and wide confidence intervals, smaller numbers, smaller events. But let's just recognize that with this subgroup, with low volume testosterone suppression plus docetaxel and possibly radiation to the prostate, had a 5-year survival of about 70 to 75% with and without the addition of abiraterone. So these patients clearly have a much better, longer survival, whether it be sequential or concurrent therapy. And the high volume patients, this is the impressive piece, where the 5-year survival went from about 33% with ADT and DOSI followed by add-on ABI or other therapies at progression, versus about a 50% 5-year survival in those who got the triplet therapy. That's the first time we've actually crossed the 5-year survival mark with a median survival of 50%. That's the first time ever. Hopefully in the next few months, we'll be able to confirm that data with enzalutamide and get more numbers in the high and the low volume. Our first overall survival was 0.67 for the overall group, but 0.9 for the patients who got docetaxel with or without enzalutamide. And then the ARASENT study, where everyone got concurrent docetaxel with testosterone suppression plus or minus darolutamide, that is pending. And here you can see a clear separation of the curve, which happens late when abiraterone was added to docetaxel. The control arm, testosterone suppression and docetaxel of 3.5 years, was very similar to the data from STAMPEDE, CHARTED, and GTUG, with about 3.5 year survival for that poor risk group with the addition of docetaxel. But what we can see is a late separation of the curve after 18 months. So clearly there are patients who are still passing away within the first 18 months, despite all the therapies we're throwing at them, but there is a longer term overall survival. Now we see patients with testosterone suppression plus docetaxel with or without abiraterone, and we can really see that there's a much better longer term survival, even with the sequential approach of testosterone suppression dosing and then adding on ABI versus giving it all up front. Not a clear survival benefit, 0.83, very few events, because I think these patients have a different prognosis and a different biology and should be considered differently. And Brian and I can have a little bit of a chat about that. Having said that, are there patients who are testosterone suppression de novo metastatic, low volume, so patients with de novo low volume who may benefit from the triplet therapy? I think there may be. Are they the patients who we cannot encompass all of their field within SBRT, for example? Maybe. But at this stage, I do not feel comfortable adding docetaxel to patients with de novo low volume. I would give primary radiation, as I mentioned, abiraterone and radiate the metastases, using the radiation as a safer, easier, more AR negative targeted therapy than docetaxel. So where does this lead us to? Brian, you asked the question, should we be categorizing patients by metachronous and synchronous versus volume metastases? I'm going to say yes, because I do think it impacts treatment decisions. We've got a good risk group, metachronous low volume, where we've got a clear survival benefit with enzalutamide, but I suspect it is relevant for ABI and APA as well. And we can consider adding on SBRT, but we should be making this a trial. Intermediate, metachronous, high volume, I suspect those patients, if they're chemo fit, would benefit from the triplet. And so I would consider that as well. It's actually a very small patient number, and they had the same treatment effect as docetaxel as the de novo high volume. But there's clear evidence of benefit with ABI, ENZA, and APA. But if you're going to choose docetaxel, I would not do it monotherapy, I'd do it as part of triplet. but again, we need trials. Synchronous low volume, radiate the prostate, or ABI, ENZA, APA, lower treatment burden, strong, consistent survival benefit. As I mentioned, I do radiate the primary, I do give the hormones, and I do consider SBRT. But if they've got, say, wide burden of nodal metastases, you can't get it all in a radiation field, and they're on the upper border of low volume, I would consider docetaxel in a younger patient, but very select and really going off-piece, if you would. And then for the synchronous de novo high volume, testosterone suppression plus ABI plus docetaxel if chemo fit, but if not, ABI, ENZA, or APA. Well, these patients are those who we should be trying to augment therapy and get new agents, targeted therapies going after key biology, and enroll these patients on clinical trials. We do know the side effect profile, and it's listed here: anemia, alopecia, fatigue, neutropenia, quality of life impairing. And there is about a 1% treatment-related mortality, aberrata and fatigue, arthralgia, hypertension, nausea, edema, hyperkalemia, hot flushes, diarrhea, vomiting. Not everyone's an aberrata candidate, especially those with congestive heart failure or liver dysfunction. Apalutamide and enzalutamide a similar side effect profile with fatigue, cognitive changes, falls, and the like. And now I'll turn it back to Dr. Rini.
Thanks, Chris. Thanks for that review. There's a lot of data there, right? I mean, as we've seen the last 5 years, there's really been an explosion of data, various combinations and high and low volume and subsets and radiation. And like you alluded to before, the chess pieces, many different chess pieces here and a lot of different data. Let's discuss this triple therapy. So the piece 1 data was just presented at ESMO. It had been presented at ASCO with an RPFS advantage for triple therapy versus double therapy in essence, and it really generated a lot of controversy. Some of it, is the way the data was presented and sort of the way the trial was done and different statistical, issues with the trial and the control, but there was a lot of controversy after ASCO and everybody was waiting for this overall survival data. We now have that survival data, and I think it's become clear. So maybe Silke, you can start. Give us your current thoughts on triple therapy and in which patients you would apply it.
Yeah, so I think, piece 1 is an academic trial and it's a very important trial and we learn a lot from it. But obviously, if you would design it today, you would probably ask a different question. You would ask ADT plus ABI plus minus docetaxel, or because you give, at least in my practice, much more hormonal agents than docetaxel, low volume or high volume. So in that sense, the question that would nowadays be the important question is really what is the added value of adding the docetaxel, the 6 cycles of docetaxel. But I fear that we won't have that data. So I guess we need to go from what we have. And it seems that triplet is really strong and really has an impressive overall survival benefit. And I'm totally okay with Chris to say, for the high volume patients who are chemo fit, I would clearly discuss it. Have to say, at least here in Switzerland, there are always also some patients who just say they don't want to have chemotherapy, even with an overall survival benefit. And I guess that is something to discuss with the patient. For the low volume, that would be really exceptional patients I would discuss it with. For example, maybe the patient that you just presented. It was very young, very fit, and I think at least the RPFS data also for the low volume are probably positive. But then that we don't know what the radiotherapy is really adding there, because that's part of the data from this one we don't have. So I guess exceptional low volume patients as well, as Chris has pointed out.
Chris, what do you think? What patients, I mean, you've kind of said this, but maybe just to reiterate, what patients will you apply triple therapy in? What low volume patients might you apply it in? Or what high volume patients might you not apply it in?
Yeah, absolutely. The first thing is chemo fitness. Let's just be very clear about that. Not everyone is a candidate for docetaxel. And I have seen patients harmed with docetaxel. And I'll also start with a statement. There's statistical purity, and then there's what we have to do for the patient in front of us in clinic. And when I look at data sets, I look for consistency across trials and findings, and also play into the biological interpretation and the prognosis of things. So I don't just look at the statistics and the point estimates and overall conclusions. I know some people have concerns about that, but I try and look at the whole data set to make a decision for individual patients. And that's why we are desperately trying to, I will say this out loud, we are close to having the number of 470 events to trigger the next analysis for ENZAMET. We hoped we would have it for ESMO, but we didn't, but we're hoping to get that data out there as quickly as possible. So before we see ENZAMET, I'm comfortable we've got a clear signal in the high volume de novo metastatic patients who are chemo fit, no question. I'm not, because low volume has a different prognosis and a much better survival out to 70% at 5 years, that's impressive. And you're giving docetaxel here, like the patient you described, for 18 weeks, and 5 years later, we're talking about overall survival. So I think there are patients who may benefit from a sequential approach with less treatment burden. The other thing to say, to answer Silke's question, we do have some sort of comparative data that Dosi and Abby look okay as doublets together, similar per the Stampede. But all of those, they all dial in at about a median survival of about 5 years with the doublet. 50 months with the doublet. If we see with ENZAMET that we again get about 50 months with the doublet, 40 months with the doublet testosterone suppression of Dosi, and 60 months with adding enzalutamide, that's consistent. And I like consistency across trials because you can't, that's very important. So until we actually voted on our Dana-Farber pathways, whether we would accept triplet for high volume, we did. We did not accept it for low volume. And that wasn't just me, that's your Mary Ellen's, Taplin's great clinician, Atish Chowdhury, Mark Pomerantz, a whole group.
And we will discuss that at APCCC on the 9th of October. I think that there we'll have 80 experts, and I'm really excited to see what will be discussed there and voted there.
What's the definition of expert?
That question, you know, would you give it in high volume, low volume, synchronous, metachronous? So I think we will have a better picture what the experts at least are thinking worldwide after that meeting.
Yeah. Hey, can I just double down on the importance of APCCC? There's a lot of work that we do, patient care that we deliver in the gray zone, and APCC really helps every clinician who doesn't treat prostate cancer regularly think through how other people are treating in the gray zone.
Yeah, thanks, Chris. We look forward certainly to that conference, that sort of conglomerate expertise. I think, you know, among the three of us, and really what I've heard from others is relative consistency, that triplet therapy is standard for chemo-fit patients with high volume and maybe some select low volume disease. I think the question of radiation, you know, we don't have that data yet, as you said, Silke, but I think the question of what is then radiation adding in that setting, or as you alluded to, Chris, can radiation maybe replace docetaxel for some patients? I don't know that trial will specifically answer that, but I think that's sort of the next wave of data, you know, to come across to inform decision-making in these patients. So certainly a lot of data out there, more data to come. You know, we're pushing median survival beyond 5 years, as you said, and that's really exciting. It's sort of a landmark, but a long way to go.
For the worst prognosis group, what would be interesting is, are we getting close to 90% overall survival for the best prognosis group? Right. So 50, 70, 90 for the different risk groups, compared with where we were with 3, 5, and maybe 7. I think we're hopefully making much more progress over time.
Yeah, I mean,
and our two big questions going forward are being, can we de-intensify therapy for some patients and stop? And what therapies do we need to add for those who are not doing well with therapies?
And it's exciting, you know, as you get more, it's a good problem to have, that you have so many active therapies that you can't necessarily agree how to use them, right? I mean, that's a good problem to have, is that, gee, you have so many active approaches, we're not sure if you should get 2 of them, 3 of them, 4 of them, radiation, you know, or I think solid tumors reach a landmark when you can talk about de-intensifying therapy, right? We have so much therapy, we don't want to overtreat people. That's not a problem we have necessarily regularly in solid tumors, or have had always in prostate cancer. So I think these are good problems to have, and conferences like, you know, APCCC and others, and this kind of webinar, I think really sort of help inform So one last question, Chris, maybe before I close, is about integration of PSMA PET moving forward and some of the biologic markers. Where is that going in prostate cancer?
So the key answer to that is we're building radiology banks with the investigator-sponsored trials, which is so important we can do that. So ENZAMET, ENZARAD, DAZZLE, and the other ANZUP studies. Stampede is doing that. So we're getting as many of the data as conventional scans and PSMA PETs so we can start to get the feel for the prognostic and the predictive value in the different treatment settings and with the different treatment types. But also we're collecting specimens as part of icecap.movember.com. You can see it all mapped out there where Dr. Gerda Tard is leading on the Stampede, and a number of us with the ANZUP group and Chartered group are collecting it. Hannah Samir, Darun Azad, Alex Wyatt, Ian Davis, a whole team, where we're getting the primary tissues for gene expression profiling, exome profiling, to see if we can work out, is it a particular profile better suit a molecular profile? Does that do better than clinical imaging markers and the like that we have? So that's the future state, but we're definitely working on it.
Thanks, Chris. And as you say, really important investigator-initiated efforts to sort of move the field forward, impressively so. So I'm going to close today just with a couple thoughts about patient-centered care. We've alluded to this a lot throughout the program of tailoring application of these individual therapies or combinations of therapies based on patient characteristics. And that's really what we mean about promoting individualized patient care. Part of it's expectations and goals of the patients. So I think the physicians, and providers come at it from one angle of wanting to maximize survival and maximize median survival, et cetera, which is of course appropriate, but patients may have different goals, right? And they may be chemo fit, but not want chemotherapy, as Silke said. So it's really around shared decision-making, educating around side effects, which Chris touched on, risk assessment, treatment response. Again, the idea of intensification and de-intensification of therapy as appropriate, which I think in prostate cancer, we're just starting to ask and answer those questions. And it's really sort of putting the patient at the center and then involving everyone around that. Family members, pharmacists. I have a pharmacist in my clinic who helps sort of with the application of therapy, my advanced practice providers, everyone who's involved in this patient care, this multidisciplinary approach to patient care, which I think in prostate cancer is becoming even more prominent, right? With the role of radiation, et cetera. I think it's always been, it's what's great about prostate cancer is involves multi-disciplines, but I think that's even more true in the modern era. We've covered a lot of ground today, and maybe I'll just let you each have one final thought, one sort of take-home point for the audience of if they had took one thing home from this webinar, what would it be? Silke, I'll start with you.
So for me, I guess the most important thing is really that there should be really only exceptional patients who receive ADT only. We know from data, like real life data, that too many patients probably don't profit from these new data that doublets, triplets, quadruplets, whatever, are really increasing quality of life, survival, and so on. And I guess what we now have to do, and I think it's our responsibility, is really to take that data out to everyone. And really, I don't see a lot of patients where I see a good reason to treat with ADT only in the metastatic hormone-sensitive setting.
Great, thanks, Chris.
Well, Brian, obviously you're following up on that, getting up to 6 a.m. there in the old Nashville to, or even before that, to start filming at 6 a.m. We need the investigators need to share this message and explain it to the wider community where most prostate cancer is treated, for sure, with Silke said. The other thing is, key message, ask the patients what they want, what are their goals, and that can help you think through what is the treatment option that may be best for them.
Great, thank you both. And I would just add, that again, keeping aware of recent data, right? Piece one was just presented. There's a lot of new data coming out, and really, tailoring that approach to individual patients and, keeping up on the latest data, because there's a lot coming out and much more to come out as we alluded to throughout this webinar. So for our audience, thanks for joining us. Don't forget to claim your CME credit by completing the post-test and evaluation at integrityce.com/mHSPC. There's a post-test there. Keep an eye out for another tutorial that'll come out this week. And as we discussed, do not miss the virtual Advanced Prostate Cancer Society Cancer Consensus Conference, which is this Saturday, October 9th. Thank you both again, and thanks to our audience.